Thank you, Madam Chairman, and I'm pleased to join Chairman Murkowski in conducting this hearing on fiscal year 2020 budget for the Indian Health Service. I'd like to welcome back Rear Admiral Michael Wiacki before the subcommittee this morning. Thank you for appearing before us, and thank you for sharing the service's budget priorities. And I see you are joined by Rear Admiral Michael Todt and the Chief Medical Officer, Rear Admiral Gary Hartz, the Director of the Office of Environmental Health and Engineering, and Ms. Ann Church, Acting Chief Financial Officer. Welcome to all of you. I'm proud this subcommittee has made major investments in tribal health care over the past several years, including increasing the Indian Health Service budget by 25% since fiscal year 2015. And a lot of that credit is due to the leadership of our chairman, Senator Murkowski, and I have been honored to fight for funding alongside her as ranking member of this subcommittee. I'm proud of our funding accomplishments, but clearly there is more work to do in fiscal year 2020. With that in mind, I must note my concern that we are beginning work on fiscal year 2020 appropriations bills without the benefit of a budget agreement. While I'm confident that Congress will ultimately negotiate a budget deal to prevent a devastating repeat of sequestration, it's imperative we put a budget deal in place that provides increased top-line spending levels. Without a deal in place, we cannot move forward with funding essential agencies like the Indian Health Service and ensure that we continue to make good on our nation's trust and treaty obligations to Native Americans. And that is all the more ironic because while the overall Trump budget is lacking, the budget request for the Indian Health Service actually puts forward important investments that we ought to enact into law. And I'm happy to see a better budget request this year than we have seen in recent years from this administration. The request fully funds contract support costs and staffing for newly constructed healthcare facilities, expands clinical care programs and access to substance abuse and mental health treatment, proposes beginning a new community health aid program to train healthcare paraprofessionals in the lower 48 states, just as the IHS currently does in Alaska, and asks for resources to continue integrating newly federally recognized tribes into the Indian healthcare system and for the administration's initiative to reduce HIV and hepatitis C infections, two preventable and treatable diseases that disproportionately impact Native populations. The budget request also includes $25 million to initiate replacement of the service's electronic health record system, a down payment on what is likely to be a multi-billion-dollar investment and a long overdue project tribes and Congress have been concerned about for years. These proposals, combined with the 2% increase overall for the agency and a 4% increase for medical services programs, are certainly a step in the right direction. But the overall budget still falls short of meaningfully addressing the healthcare needs of Indian country. And I'm concerned by some of the trade-offs, cuts, and false choices that are proposed in the budget. Funding for health education is eliminated completely, and the urban Indian health programs are cut by 5%. Line item construction is slashed by 1/3, a retreat from important investments that this subcommittee has made over the last few years. I reject the notion that cutting construction makes any kind of sense when some of these projects, like the replacement of the Gallup Indian Medical Center in New Mexico, has been on the priority list for nearly 3 decades. There are more than $2 billion worth of construction projects in total on the current priority list and billions more in additional facility needs once those are completed. I'm also disappointed that the budget does not continue the $10 million for tribal grants to combat opioid addiction that were funded by this subcommittee in fiscal year 2019. And although some new funding is devoted to recruitment and retention initiatives like special pay authorities and housing subsidies, the budget request cuts funding for scholarship and loan repayment programs by nearly 1/4, or $14 million, even though the service's inability to recruit and retain healthcare professionals is a major reason why the agency has been part of the GAO high-risk list for the past several years. Another administration proposal related to recruitment and retention in the budget asked to expand the use of Title 38 authorities used by the Veterans Administration at the IHS. In previous years, this subcommittee has encouraged you to make use of incentive programs like those found in Title 38. But this year's legislative request proposes access to a much broader set of authorities. We need to fully understand what impact these authorities would have on the workplace rights of employees. God bless you, Mr. Hartz. The administration's request would also cut funding for the Community Health Representatives Program by 60%, in part to help pay for the proposal to establish the new Community Health Aid Program. Tribes in New Mexico and across the country use this program to provide frontline health education and wellness services and to transport patients in my state to doctor's appointments that can be hundreds of miles away from tribal members' homes. We should not cut the Community Health Representative Program to fund the Health Aid Program when both programs fill different but important gaps in healthcare service in Indian country. There are other challenges that the service faces that we need to address. I want to hear from the service about what steps the agency has taken to protect Indian country from horrifying misconduct like that of Stanley Patrick Weber, who was convicted of assaulting young patients over the course of several decades while serving as an IHS pediatrician. And I join the chairman in her statements as to how disappointed and discouraged she is with what happened there. As part of that, I expect the service to discuss the steps it is taking to improve its employee screening and credentialing system and to ensure that any workplace incidents are properly reported and documented. Employees with history of egregious misconduct must not slip through the cracks. And finally, given the recent partial government shutdown and potential for ongoing uncertainty during the fiscal year 2020 budget cycle, I look forward to having the opportunity to discuss advanced appropriations with you, Admiral Wiyaki. Even though a few months have passed, I want to make sure that Indian country knows that we have not forgotten the hardships caused by the government shutdown earlier this year. I saw what happened in New Mexico, and I heard from tribal members across the country about the terrible price of the 35-day lapse in funding. Whether it was medical providers working without pay, urban organizations forced to cut services and even close their doors, or tribes struggling to keep ambulance services running, the impacts of the shutdown were far-reaching and caused enormous suffering. I want to make sure that tribes never have to worry again whether basic health care services will be provided in the event of a shutdown. And that's why I was proud to introduce legislation, the Indian Programs Advanced Appropriations Act, and that would provide funding certainty for the Indian Health Service and the Bureau of Indian Affairs by allowing their budgets to be funded a year in advance. I know that my colleague, Senator Murkowski, has sponsored similar legislation in past Congresses and has been a leader on this issue. I'm hoping that we can work together on a bipartisan basis to pass legislation to authorize advance appropriations, and I look forward to working together on this critical goal. Admiral Wiyaki, I look forward to hearing your testimony.